abogado y director del programa de Medicina de Urgencias del Keck School of Medicine de la Universidad de Southern California. Hoy día nos va a hablar de Mejorando el manejo del dolor. Bienvenida, doctora.
Gracias. Buenos dias. Yay. Good morning. Good morning. Everybody waking up, have their cafe. Yes. Good. This morning we are going to discuss pain management. Now, if you think about all the reasons that people come to us to seek our care, pain is certainly one of the most common reasons. And so we really need to be experts at dealing with patients' pain. Because although we, in our mind, are very interested in seeking the diagnosis, and the patient's interested in that too, they're very interested in feeling better and making their pain go away. So we need to be experts at doing this. This picture that I have on the first slide here is a picture that a patient drew who was in a lot of pain, a patient who actually has chronic pain. Today we're going to talk about acute pain. But patients who have chronic pain have to deal with that in many ways, and art therapy can be a very helpful modality for those patients. So we're going to talk about managing acute pain in the emergency department and some of the ways that we might be able to do better. So we're going to review some of the common mistakes, the things that we commonly do that we could probably do better with. We're going to talk about some strategies, including medications, and some things that are not opiate medications. And I hope that you learned something new from this lecture. The first thing to say is that we have to accept that we all have room to improve. Could we do better at our pain management? The answer is yes, and we actually have literature to support that statement. There have been several studies looking at pain management in the emergency department specifically. This one was one of the larger ones, looking at multiple emergency departments in the United States, looking at 850 patients with moderate to severe pain. And what we found was that it was uncommon for us to go back and reassess the patient. How are you feeling now? Not just once, but multiple times. Uncommon. And often patients had great delays to getting their pain medicine, a median of 90 minutes. Imagine lying with moderate to severe pain for 90 minutes. And many of the patients, when they walk out the door to go home, are still in quite a bit of pain. This graph illustrates that. If you look over time, on the bottom here is the intensity of the pain, and then on the upper axis is the percentage of patients. The black bar is when they came to the emergency department, how bad their pain was, and the white bar is when they went home, what was their pain score. And you see there's still quite a few people discharged to go home with pain scores of 10. So often we haven't really reached the goal that they came to the emergency department for. We know that this is true in children as well. This was a paper looking at children, pediatric patients with fractures, 800 children, 94% of them went to have surgery. So these were not small fractures, these were pretty major fractures. And 60% of those children received no pain medication within 1 hour of arrival, lying there with a fracture, 1 hour, no pain medicine. And only 10% actually got adequate doses of pain medicine in the first hour that they were in the emergency department. So we can do better. We know from the literature that emergency physicians have a harder time dealing with pain in older patients, in pediatric patients, and it's also been shown that we often are discriminatory with our pain medicine with patients of other ethnicities than ours. In the United States, it's been shown that we treat African Americans differently, we treat Latino patients differently, and we often are unable to communicate properly and make the right thing for the patients of other ethnicities. So we have to just recognize that we can do better with everyone. The next one is to get away from the idea that just because someone doesn't look like they're in pain, that they're not in pain. There's really no reliable way to know if somebody's experiencing pain. Often we are ordering pain medication for someone and we're reminded by a nurse or a colleague, you know, that guy doesn't look like he's in that much pain. You really want to give him more morphine, you know. I went back in there, they seem pretty comfortable. The truth is that pain is a very complex experience, and people manifest pain in different ways, and you've probably seen this. These are multiple papers validating this idea that although, yes, sometimes patients in pain can have increased heart rate, sometimes they have increased respiratory rate, this isn't 100%. You can't always rely on those objective signs. Multiple papers explaining that idea and getting rid of that myth that fluctuations in vital signs are not reliable indicators of the intensity of someone's pain. So pain is a complex experience. You can't reliably tell whether someone's in pain or not. So the bottom line is that you have to ask the patient, do you need more pain medication? It's a very simple concept, except that you can't always tell if someone's in pain. The next thing is to remember that we have to reassess. Someone comes in, they're in a lot of pain, we write the pain order, done, right? That's often our day, our workflow. We write the pain medication, we move on to the next thing. But the truth is that we need to always go back and reassess the patient. How are you doing now? Do you need more pain medication? And don't forget to empower your patient as well. Remind your patient, if you need more pain medication, don't be afraid to ask us and make them part of the team. Going back and saying, how are you doing? How are you doing? It shows that you care, and often you'll find that they do need more pain medication. So treating pain is a team sport. The nurse is involved, you're involved, and the patient is part of the team. And they need to take responsibility for that and help us understand if their symptoms have improved. Let the patient decide how much pain medicine they need. Sort of a novel concept. We know that protocols that include as part of the protocol asking the patient if they need more pain medicine is a more effective way of treating someone's pain, including the patient in making that decision. We know in the emergency department the best way to deal with patients that are in moderate to severe pain is by titrating opioids through the IV, and that will be our best chance at controlling their pain. This is a paper from 2011 that described a very successful protocol of using hydromorphone, or Dilaudid is the trade name in the United States, and using what's called the 1+1 protocol. Treating someone with 1 milligram, waiting 15 minutes, and asking, do you want more? And if the answer is yes, 1 more milligram. And they actually randomized patients to receive this protocol versus just however you usually do it. And we saw that there was more treatment success, more pain control in the group that had the protocol, and it was very safe. 1 milligram of hydromorphone is about 7 to 8 milligrams of morphine in terms of equivalence. So for some people, this seems like a lot of pain medicine, but in fact, we probably underdose our pain medicine in general. This is a study from 2005 that showed that although we teach people that the dose of morphine for adults is 0.1 milligrams per kilogram, and that's sort of a standard morphine dose, in fact, if you use that as your approach to pain medicine, pain treatment, only about half of patients who receive that dose will have their pain adequately treated. So most adults need more than that, and the only way we'll know is by going back and asking them if their pain has been adequately treated. The next thing is to remember to be careful with mixing lots of different medicines with different potencies. And often patients who are in a lot of pain, they might need some kind of a procedure. We might decide to go to procedural sedation. And although opiates are very safe, as we start to mix them with other medications, we can find that we get ourselves in some trouble. One example I would give you is patients who, as I mentioned, may undergo some kind of a procedural sedation with something like propofol or etomidate, and they've already received a lot of morphine or opiates for their pain. And often as you start to combine medications, you can get those side effects that we worry about. This is especially true in patients who are not used to getting lots of opiates. Things do add up. So always remember that Narcan or naloxone, our opiate reversal agent, can be very useful in those situations, and you should always have it available because you might need it. Ketamine is also another good alternative, and you may not run into this problem as much. So be careful about combining lots of medications. The next pearl is to remember that not all pain is created equal. And sometimes you have to think of other things to do for patients. When you ask patients to describe their pain, there are lots of different types of pain. The somatic pain, visceral pain, neuropathic pain, and the descriptions and the different ways that patients describe their pain can lead you to maybe what the best treatment is. So, besides just morphine or hydromorphone, what are the other things that might actually relieve this patient's pain? And there can be lots of other things on the menu. There might be gabapentin. There could be topical analgesics, maybe steroids, maybe in some patients, anticonvulsants for patients who have unusual types of pain. Caffeine for post-lumbar puncture headache or migraine therapy, antidepressants for chronic pain. Just remember that there are a lot of things besides opiates that we use to treat pain, and you should explore those options in terms of your patient's type of pain that they have. There are some types of pain that are specifically prostaglandin mediated. And in fact, for those patients, NSAIDs or non-steroidal anti-inflammatories are probably the best choice for those patients. Those specific types of conditions include these: renal colic, kidney stones, biliary pain, gallstones, uterine pain. NSAIDs are probably the best way to attack those types of pain. Another thing is to remember about nerve blocks. What about local or regional analgesia? Can provide quite a bit of relief. We talked a little bit yesterday about dental pain, and in fact, nerve blocks for those patients can be very effective and very easy to do. This is an example of just doing a single tooth nerve block, very straightforward, and it just involves putting on some topical analgesia and injecting some bupivacaine or lidocaine. These are the types of needle syringes called ring syringes that dentists use that make injecting these types of medications very, very easy, but you don't have to have one of these to do this. It just makes it a little bit technically more easy. That's the mechanism that you would use to do just a simple dental block, but you could also do regional mouth blocks as well, such as an inferior alveolar nerve block where you can take out a region of the mouth. This can be useful for dental pain, but also for laceration repair in the mouth as well. And these can be very useful adjuncts for your patients in terms of relieving their pain. We all know that dental pain can be one of the worst, most torturing kind of pains that you can have. So these can certainly be very, very helpful to give people longer lasting relief. They're pretty easy to perform. Another type of pain relief that you might not be as familiar with is to use your ultrasound machine to do a nerve block. And these are actually fairly easy to do once you teach yourself how to do them. And there's lots of different places in the body that we can do these nerve blocks that can facilitate abscess drainage or just give pain relief. Radial, ulnar, median nerve blocks, femoral nerve block for hip fractures. This is a picture of a femoral nerve block. And you basically need to identify the nerve, which looks like almost like a little, they describe it as sort of like looking like Swiss cheese or something with a little bit of holes in it. And you can surround that nerve with the pain medication, the bupivacaine, the lidocaine, whatever you're using. This is a patient who's got a very large abscess. This was published in one of our journals, who's receiving a abdominal wall block to provide the analgesia needed to drain the abscess. Because there are some patients where maybe you don't want to use a full sedation protocol for some different reason in that patient, and a nerve block may be the best answer. Another type of analgesia technique that we're starting to use is to use low-dose ketamine, which can be a very useful adjunct to our sedation. And this is relatively new in terms of our practice now, but it is not a new idea. This has actually been around for many, many decades, and in fact, in the anesthesia literature, this is a paper from 1971 describing the analgesic effects of ketamine using in a sub-dissociative dose. So this has actually been an idea in anesthesia for a long time, but relatively new to our practice. How do you use it? Well, you can use it alone, or you can use it with opioids. It can be useful for those patients who suffer from very complex neuropathic types of pain, such as the regional pain syndromes, reflex sympathetic dystrophy, or fibromyalgia. This can be a good adjunct for those patients. The dose can be anywhere from 0.2 to 0.6 milligrams per kilo. There's a range. And you can use it whether it's a single dose or an infusion, different ways of delivering the ketamine. There's been a few papers published on this describing the use in the emergency departments. This was a very small, just a survey of 24 patients who received this low-dose ketamine and the clinicians who treated them. And they found that 2/3 of the patients who received the ketamine were satisfied. Their pain was relatively well controlled. And overall, their pain scores did decrease. Some went all the way down to 0, some not all the way down. And the dose in general in these patients ranged from somewhere between 10 to 30 milligrams of ketamine that was administered. The patients were asked to describe their experiences with the low-dose ketamine, and some of them described it as a good trip. I was in heaven, I was floating, I was on TV. And some people said it was a bad trip, it was scary. It was in quicksand, it lasted forever. So people have very different experiences with ketamine, but it does seem to be useful in controlling pain. Don't forget about delivering your medications in other methods besides the IV. This is a paper describing using nebulized fentanyl in children, and so we've been using intranasal or nebulized forms of these drugs as well. They can also be useful adjuncts. This has been mostly shown in pediatrics because we like to avoid starting IVs in pediatric patients, but just keep in mind that there are alternative routes out there besides the standard IV route. So in summary, for acute pain, patient-driven solutions, including the patient on your team, empowering them to ask for more pain medication, including their family to advocate for them as well, is really important, and reassessments are key. Don't forget that pain is a very complex experience. Just by looking at someone, you can't automatically tell if they're in pain or not. You have to ask a patient, do you need more pain medication? You have to believe that their experience is what matters. There are no absolute reliable ways to tell if someone's in pain. You can't always count on an increased heart rate or an increased blood pressure. And think outside the box. Although opiates are a very good way to treat pain, there are other ways that we can go about this. And you have to be creative sometimes in thinking of ways that we can relieve someone's pain. And we'll do a much more effective job. Thanks.